There's a bar on Kingston Street called Lenny, where we used to go. Still too far from the bottom of the bar. All right, Aggies, welcome back, welcome aboard. It's time for another episode of Exercise Biomechanics. Today we're going to finish up our discussion about Wolff's Law and bone mass. And then we're going to take some time to talk about tendon biomechanics. Incredibly important as we start to focus on what happens in connective tissues. So that means not only bones, but tendons, ligaments, cartilage. They'll be the focus for our discussions this week and the first half of next week. So welcome aboard. We're going to take just a moment here to get started. I think last time, let me hold on a second. Last time we were talking about the effects of spaceflight on bone mass, and you can see where we left off last time. I'm going to adjust this a little bit. Hang on there. There we go. A little adjustment here and there. That's probably good. All right, very good. Okay, with spaceflight, one of the things that we noticed was that in the Gemini missions originally, and then there were longer Skylab missions in the 1970s. And since really the mid-1980s, lots of space flights and a chance to really look at the long and short-term effects of spaceflight on bones, tendons, ligaments, cartilage, and skeletal muscle. So one of the observations that was made really early on, it has continued, was calcium and a lot of nitrogen showing up in the urine where the levels really shouldn't be so high. So clearly the calcium was coming from bone and nitrogen, of course, from skeletal muscle for the most part. So the calcium that was coming from bone appeared to be coming from the cancellous bone. So when astronauts were coming back from spaceflight, we would take a look at their bones with a bone scan, and we would see a reduction in bone mass, particularly in cancellous bone. Cancellous bone has greater surface area, and so therefore it turns over proteins at a much higher rate. The bone mass loss, there was something different though between muscle mass loss and bone mass loss. Bone mass, unlike skeletal muscle mass, the loss of bone mass, like per month, doesn't really slow down very much. The longer someone's in space flight, whether it's 1 month, 6 months, a year, or 18 months, the longer you stay in space flight, the greater loss of bone mass there is. And it seems to be kind of at a steady rate. In skeletal muscle, in contrast, what we see is the greatest loss of muscle mass in the first month. It doesn't stop then, but it really slows down, tapers off. So there's a slow loss of skeletal muscle mass after that as it doesn't really reach a plateau, but it doesn't continue the same way bone mass does. And the real problem was that people who were in spaceflight for close to 12 months or even up to 18 months with the Russian Soyuz and Mir missions back in the 1970s and 80s, what we were seeing was a significant loss in bone mass, about 10 years worth of what we see after age 50 or age 60. So literally almost 10 times faster than you see with osteoporosis. Pretty amazing. So people started to look at what happens here back on Earth. That's where Chris Kahn discovered the female athlete triad. Barbara Drinkwater then did a series of classic studies after that, starting in the mid-1980s through the 1990s up till about 10 years ago when she retired. So the data was pretty clear that we were definitely losing bone mass. So part of the notion of trying to do exercise training is to try to make up for that reduction in basically mechanical loading or mechanical stress that happens during spaceflight. So that's been where a lot of, and you can see someone exercising here, been where a lot of the research is. How can we exercise someone optimally? And at the same time, how can we combine maybe nutritional or therapeutic drugs to try to reduce the amount of bone mass loss and even skeletal muscle loss during spaceflight. So comparing spaceflight and inactivity, the effects of spaceflight are pretty rapid on bones and tendons and ligaments. They tend to lose mass, and because of that, they lose strength, they lose some stiffness, and they lose toughness, the ability to be able to absorb a lot of energy. That means when they come back into a loaded environment, such as Earth or even a partial gravity environment of the moon or Mars, then the chances of getting a bone fracture or a joint injury are greatly enhanced. So we really get concerned about that. So during space flight, one of the things that we noticed was a change in hormonal levels. So growth hormone levels drop. And it looked like there was a disruption in estrogen and testosterone as well. So with a reduction in growth hormone and androgens, what you might see is a reduction in growth factors, and that's exactly what we see. Insulin-like growth factor in bone is reduced. So is transforming growth factor. So is platelet-derived growth factor, vascular endothelial growth factor as well. And when that happens, you get an increase in osteoclast activity, and osteoblast activity decreases. And with that imbalance, you start to lose significant amounts of mass. So compared with aging, it's much more rapid. It does take place in the same kind of bone. That's cancellous bone that you see at the end of long bones, and also in your vertebral discs. So someone who's been in space flight for quite a while on the International Space Station, the concern is they might be a greater risk for osteoporosis when they're in their 70s or 80s. One of the things to keep in mind is that, tweaking a thing or two here. Hold on a second. Okay, the wonders of email and notifications. Try to turn off the email and dingies and that type of stuff. So getting back to space flight and inactivity, we do see some hormonal changes, which means we see some reduction in key growth factors that help to increase protein synthesis, help remodeling of the bone, can be involved in bone hypertrophy that happens with like resistive training. But here with unloading, chronic unloading, we have a lot of problems. So one of the questions is, does this relate to long-term sedentary lifestyle? One, in a way it does, because what we see with long-term sedentary lifestyle is reduction in these growth factors. Not quite as dramatic as we see during spaceflight. So it means that there is some reduction in bone mass loss with sedentary lifestyle and with metabolic disease, but it's a lot slower. So it's not even quite as much as we see with osteoporosis after age 60, 65, or 55 is more like it, after age 55. But it's there, and it's a big concern. So exercise has been absolutely critical in trying to mitigate this. Right now, as I mentioned, it takes about 2.5 hours of space flight to try to mitigate some of those losses in bone mass and skeletal muscle mass that we see with space flight. So there have been a lot of different types of studies. The best ones seem to involve significant amounts of compression because it's compressive loads that we really lose when you're in a zero gravity environment or microgravity environment. And that is the compressive loads that you would normally see, there we go, on a femur or tibia or the spine. Those are greatly impeded. So there have been a lot of different types of exercise machines. There have been some bungee treadmills. Here's kind of a semi-bungee cycle. So cycle ergometers and treadmills, we tried those with spaceflight. With the Skylab missions back in the 1970s, they didn't work really that great. If we can increase the compressive load, so these rollers on the shoulders help to do that. Part of the problem is it's not just simulating the kind of static loading that you see in a gravitational environment. But it's the dynamic loading that you see when someone is taking a step, because that can be not only 1.8 times your body weight, and with running is 3.5 times your body weight. It's basically the change in force divided by the change in time, the derivative for you fans of calculus. But the idea is the slope of that line as that force is rising. That steep slope, that's the thing that the cells are seeing. The osteoblasts, osteocytes, and osteoclasts that start to crank up the remodeling process. So one of the ways we started to try these different types of interventions was to use something called the KC-131. And that's an airplane that does a parabolic flight. So the best way to describe it, it's like being on a flying roller coaster. So the plane goes up in altitude, you can see about 9,000 feet, and then it drops off back down 9,000 feet. So kind of like one of those scary airplane movies. It really does work like a roller coaster. So when you get near the top and start to roll off, you get 0 G's for a period of time. It's about 30 to 40 seconds, but it's enough time for people to try to figure out, well, how is this going to work in a gravity-free environment? It's a little bit more difficult, but we've also done this in pools, like the deep end of a pool, where you have about 12, 15 feet of water, and you can practice this type of stuff underwater as well. The KC-31, of course, has a unique name. It's called the Vomit Comet. And that's because as you're going up and down like a roller coaster, people get a little queasy right about there when their stomach ends up right here in the throat, or that's what it feels like at any rate. Okay, so there have been a number of exercise devices that NASA has been working on over the years. This is an iRed machine, very similar to the ARED machine that's currently in use. The ARED machine can work out a number of different muscles and joint systems. It looks a little bit more, I guess, like a squat machine, if you can imagine that, with some additional types of uses. I think there's been a new generation of ARED that takes into account some of the things I like about the iRed machine, and that is this one's more like a leg press, where you have significant amount of compression acting on the legs, acting on the spine. So a little bit like a squat exercise. And it also involves the flexor muscles in the upper extremities. And those are the types of muscles: flexor in the upper extremities, extensors in the lower extremities in the spine. Those are the muscles that are basically not getting the workout in space flight. So it helps not only the bones, but obviously the skeletal muscles, and gives you dynamic loads that are a lot higher than some of the exercise devices we had in the past. Again, having said that, even with the ARED machine, it's 2.5 hours a day of exercise. So NASA's trying to figure out, well, how can we improve this? Can we add maybe a nutritional supplement or a therapeutic drug that won't hurt the astronauts to try to move this along? There we go. So there's Julius Wolf again. And now we're going to be talking about increasing mechanical loading and stress that happens with exercise. So exercise effects on bone mass health are pretty extraordinary. Now, they aren't as dramatically large and as quick as what happens with spaceflight in the opposite direction. You can lose, about 10, 15% of bone mass in a year of spaceflight. Whereas with exercise training, if you can gain in bone mass 2 to 4% per year, you're doing pretty good with cancellous bone. Okay, so Wolff's law: bones remodel according to functional demands. And here the functional demands are an increase in loading that happens with exercise, which increases mechanical stress and strain. The bones do respond. They grow stiffer, stronger. They're able to store more energy. And so therefore they are indeed tougher. and they're less likely to be fractured. So that's one of the preventative aspects about exercise. And one of the things about exercise training and skeletal muscle, we said the longer you're in space flight, the more mass a bone loses. But the more you exercise year after year, the more bone mass, especially in a someone who's young or a young adult, we can see an increase in bone mass year after year. It's almost like rings on a tree that we're seeing an increase. So really pretty dramatic if we think about it. Again, not as dramatic as what happens on the other end with unloading, but certainly really important, especially if people are able to maintain either resistor training, weight-bearing exercise, playing tennis. All of these are really good for our bones. We do have to watch overtraining, and that's like over 60 minutes of continuous exercise without a break. So when kids are playing soccer, for example, every 10 or 15 minutes, you take a break, have an orange, drink maybe some Gatorade, etc. Rest up for a few minutes, maybe stretch it out. That is absolutely critical in terms of maximizing the benefits on bone as well as other connective tissues. So there have been a lot of animal training studies over the years. Some of them have been rodents. Some of them have been, these are Yucatan swine. These are not the typical pigs you might see out on a farm. They are really good models for the cardiovascular system as well as connective tissue. So a lot of coronary artery and heart studies have been done in these types of pigs because their hearts are very similar to the size we see in humans. And if you feed them a really gnarly, fatty diet, they'll start to recapitulate what happens in humans. But for the most part, they've been really pretty good at exercise as well for both cardiovascular health. And in this case, we're talking about musculoskeletal health, how we can increase the strength and stiffness of connective tissue. A lot of times they're done with young pigs because they're more trainable. So 6 to 12 months of training is almost like 6 to 12 years in a human. It's at least half a decade. So it's giving us an idea of what's happening over time. And human studies have kind of corroborated this in that the longer term studies definitely see a big increase in bone mineral content and bone mineral density. Whereas a 6 month to 12-month study in a human, not in a pig, but in a human, might give you 2 to 4 to 5% increase. But if we're talking about a study where people have been exercising vigorously for 10 years, then we can see up to a 30% increase in bone mineral density or bone mineral content or both. Okay. So these piggies, they run pretty well on the treadmill. There have been, of course, lots of rodent studies. There have been a lot of dog studies as well, which benefits, of course, not only humans, but the dogs. So maintaining strong musculoskeletal health in dogs is incredibly important. Some breeds, as you know, can get arthritis later on. So this can be a real benefit, keeping that dog in physically good condition will increase its lifespan and increase its health span. There are a lot of dogs that are really active and like to be active. Our dog Trixie right now is collapsed and sleeping, but if she's not, then she likes to be out there and likes to walk at least every day. Okay, this is from Savio Wu's laboratory, classic laboratory. He is one of the pioneers in the effects of exercise and immobilization on skeletal muscle and particularly connective tissue mechanics, bones, tendons, ligaments. I think he even did some cartilage studies as well. So we're going back to a classic study with the miniature Yucatan swine. They exercise for 12 months. And again, it's like 5 years to even 10 years or more in the lifespan. So pig years, if you will. So when we look at the cross-sectional area of the bone, and here we're looking at the femur, you can see a dramatically increased bone cross-sectional area, 23%. That's really large. You'll never see that in a year. 3% is really good. Moment of inertia. Okay, remember the moment of inertia is a constant times the mass times the radius of gyration squared. So it not only is helpful, remember, in terms of torque, but it also resists against bending forces. So this is a really important marker for people who are doing bone research. And the moment of inertia, it's in around two axes, or in two planes, if you will, the x-axis and also the y-axis. So for the x-axis, that would be sagittal plane, if you're wondering. And for the y-axis, that will be the transverse plane in a pig. So I guess it's kind of sideways. 21 and 27%. So big changes. And this is actually recapitulated in some exercise studies in humans. So this is this is a classic study. With humans, we have to keep in mind a lot of different stuff. Cross-sectional studies versus longitudinal studies. Longitudinal studies means that we take like a couple of groups and we follow them over time. Maybe one group gets an exercise intervention, or maybe a drug, or maybe a combination of both. Cross-section means that, let's say it's an aging study. Instead of following a person for 40 or 50 years, we're looking at people who are now 20, 30, 40, 50, 60, 70, 80 years of age, and looking at their bone mass. Cross-sectional studies are obviously easier to do. It takes a lot less time. It costs a lot less money, but it doesn't give you the kind of strong data that you get with longitudinal studies, because there you can really establish cause and effect. With cross-sectional studies, you really get a correlation. People who exercise a lot have higher bone mass, and people who don't have low bone mass. But it doesn't tell you whether they started off that way or whether there's more of a genetic potential in the athletes. So the only way to really track that is with a longitudinal study, where you can test before and after an intervention. The exercise protocol is really important. The type, the intensity, the duration. Specificity means, are we targeting bone sites that actually suffer from osteoporosis or are likely to get fractured? So for osteoporosis, that would be the distal radius. That would also be the thoracic spine, and also the neck of the femur. Those are the sites for fractures in the elderly. So hip fractures, spinal fractures, fractures of the back, and the wrist fracture. So that's where they occur. All three of those sites, and these are the predominant sites with osteoporosis. All three sites are made of cancellous bone. One of the big issues, of course, with human studies is compliance. Will people actually comply with what the scientists want to do? Will they stay in the study? It's sometimes hard to stay in a study a long time. Oftentimes, human subjects are paid. Not always, but many times they are. And especially with a longer term study. So some type of reward for their time and their effort. As we've seen recently with like the protests regarding state shutdowns with the COVID virus, it's sometimes hard to get people to comply for a long period of time. And for many people, I think this last 40 days, it's only been really 5 weeks of shutdown for us here at Texas A&M. It might feel like 6 pig years or 6 human years or whatever it is right now. Okay, so compliance is an issue. You have to keep in mind, of course, gender, measure hormone levels, testing, keyword, testing, estrogen, testosterone, cortisol levels, growth hormone levels. Are the sites appropriate? And of course, we keep in mind what type of bone scans we use. There's DEXA, and X-ray photon absorptiometry. That's a classic type of bone scan. You can use light beams, dual emission photon absorptiometry, computerized tomography or CT scans. Chris Can, by the way, was one of the developers of the QCT and the CT scan. So here's a CT scan, an anterior and posterior view of a person. And here you see someone going in. I think this is a DEXA, this might be a dual emission photon absorptiometry scan, if I remember correctly. Okay, So here's a couple of classic human studies. Um, this one is sort of a cross-sectional study, but within the cross-section, we actually have a control. And the reason we do is this is Roger Federer. You may recognize him, a very famous tennis player, probably one of the top 2 or 3 best men tennis players of all time. Some people would rank him #1. He hits the backhand with one hand. This used to be commonplace in like the 1970s and before. And that meant that every time the ball struck the racket, whether it was a forehand shot or an overhead smash or a serve or a backhand, it's always with one hand. So that means that the muscles and bones are stressed a lot more. So this is a classic study from the 1970s when a lot of people played tennis and use that one hand backhand. You can put a lot of backspin on it. So that's the reason that he liked it. John McEnroe used to hit a one-handed backhand as well. And if you look at this, they looked at this Jones et al. Study. They looked at the bones in the dominant arm versus the non-dominant arm. Then the non-dominant arm acted as a control because they had an extra control. In the sedentary individuals, people who didn't play tennis for like 10 years and beyond, the humerus in the non-dominant arm and the dominant arm were roughly the same thickness. So that meant we had a pretty good control. So when they measured using X-ray absorptiometry, I think this was like an ancient DEXA scan, they found a 30% difference in the dominant humerus or the dominant arm humerus in the tennis players. So that's pretty significant. We won't see anywhere close to 30% in a single year. And this was the first clue that we think the effect of exercise on bone mass in a young person is actually additive. So when you're playing tennis or you're exercising or doing some resistor training, you're going to see a spike in growth hormone. The pituitary gland is going to release a lot of growth hormone related to the stress. Remember, growth hormone can activate IGF-1, the insulin-like growth factor 1. That's what actually helps to put on the extra bone mass by increasing protein synthesis. It increases osteoblast activity. Other growth factors are also increased or stimulated with the mechanical stress of playing tennis and exercising. Platelet-derived growth factor, for example, transforming growth factor would all be increased. So the next human study, classic human study, also from the 70s, was done in Scandinavia, in Sweden. This is Nilsson and Westland study. And this is a cross-sectional study, but it's really interesting. They have 2 non-athlete groups. One were couch potatoes. One group exercised on a near daily basis, and they had some athletes. Some were local athletes, and then they had some with world-class Olympic type athletes. And they looked at the bone mass of the femur. So this is an interesting cross-sectional study. Here's bone mass. They use dual photon absorptiometry, if I remember correctly. And in the athlete group, you can see the highest bone mass. Here are the top rank athletes. And then our so-called ordinary athletes. Notice that the quadriceps force is higher for the non-athletes. We think that was a contributing factor as well as the body weight. They were just larger, more muscular. The stronger the muscles are, the larger a person's muscles are, the greater the bone mass is going to be. There's a direct correlation between the two. From a causal analysis standpoint, muscles tug, produce tension on bones. That can produce tension and compression on the inside of bones. So with that extra mechanical stress, you do see an increase in bone mass. But notice the ordinary athletes, let's see, quadriceps force a little higher than the non-athlete groups. There were 2 of them. Their weights are just about the same. So I think because of a little bit more strength, there's a little bit more bone mass than in the exercising controls, but they still have a lot higher bone mass. This is about 25%, 20 to 25% higher bone mass than the couch potatoes. Couch potatoes are the same weight, Their strength was roughly about the same, fairly close, but it was simply the fact that they were exercising every single day, doing mostly weight bearing type of exercise. So this was another clue that exercise, especially long-term exercise, these weren't short-term, these people have been exercising for years, resulted in a fairly substantial increase in bone mass. So we're looking at 20, 30, 35, well, it's about 50, 60% higher bone density. That's a big difference. But that didn't occur in, we think, a year's time. This took place probably over maybe a decade at least. And we think that at least with the ordinary athletes, those differences are probably not due to inherent genetic effects on the bone itself. It was actually the training that was doing it. Okay, so a lot of studies since the 1970s, and the preponderance of the literature tells us that we can get a significant increase in strength and stiffness with long-term exercise training. Because we've had a lot of animal studies over the years, we know about what type of change we might see in bone mineral content or density, what that means in terms of strength. So if you have probably 2, 3, 4% increase in bone mineral density, that's going to correspond to an 8 to 10% increase in mechanical strength. If you're talking about a 30% difference, then that's going to be close to 100% increase in strength, right? Probably 80 to 90% increase in strength. That's substantial. Even with 6 months or a year of training, that could be the difference between a bone fracture during the season and during some intense exercise or competition, and basically not getting an injury at all. So strength, stiffness, toughness are increased with exercise training. The best type of exercise is weight-bearing exercise and also weight training. It doesn't have to be this intense, but weight training. It's that combination of growth hormone, IGF-1, VEGF, transforming growth factor, platelet-derived growth factor. They basically help to drive that bone mass. It takes a while. It's nice and steady, though. The longer you do your exercises, the greater the benefits are. So this is one of the reasons why we think that a lot of osteoporosis is possibly possibly prevented with long-term exercise. So that's really, really exciting to us. With exercise training, there are effects on the cytoskeleton. You get fluid shear, prostaglandins, growth factors. These are the things that are driving the increase in bone mass. IGF-1, vascular endothelial growth factor, which produces angiogenesis, platelet-derived growth factor. We think those are at the cell level as potential mechanisms increasing bone mass. So from a bottom line standpoint, you just need to remember that when people are exercising, to maximize the effects, positive benefits on bone, caloric intake needs to be sufficient, calcium levels need to be good, vitamin D intake needs to be good, and of course, levels of estrogen, testosterone, growth hormone, we hope will be normal. Okay, so that's our lecture related to biomechanics on bone and the effects of Wolff's Law on what we see in bone. We're going to pause just for a second, come back and talk about tendons. Okay, howdy, we're back. And it's time to talk about connective tissue, connecting things. So here we're going to be focusing on the biomechanics of tendons, ligaments, and cartilage. Tendons, of course, attach skeletal muscles to bones. Their job is twofold. They transfer tension from muscles, which in turn produce torque, rotation of joints, and also helps to produce stabilization of bones and the joints themselves. Ligaments connect bone to bone. Their job is to act, first of all, as a sensor of joint position as well as changes in joint position. And then secondly, their function is to provide support against unwanted movement. So stabilization of joints is a critical aspect of what ligaments do. And cartilage provide cushioning or shock absorbing ability, the ability to be able to reduce the level of impact forces. And fascia, of course, is associated with skeletal muscle, like the epimysium, endomysium, and paramysium. Okay, so muscles connect bone to bone. Here's the hamstrings group. Here's the origin up in the ischium, as well as the femur for the long head and the short head of the biceps femoris, the semimembranosus and semitendinosus. They're going to attach on the medial side, if I can get this right. The biceps femoris should attach on the lateral side. That's good. This is actually anatomically correct. You have to watch it with biomechanics text because some of them are not anatomically correct. I've actually switched the picture to make it anatomically correct. Here's the semimembranosus and semitendinosus on the inside. Sometimes an orthopedic surgeon will use the semimembranosus or semitendinosus tendon as a replacement for an ACL with an ACL graft surgery. It's usually, though, the middle third of the patella tendon. So here we see the Achilles tendon. This person's a lot taller than I am. They have a very long Achilles tendon going up to both heads of the gastrocnemius, which, yay, anatomically correct, is actually crossing the knee joint. So remember, the gastrocnemius produces knee flexion as well as plantar flexion of the ankle. And here's a view of a cadaver Achilles tendon, a lot shorter, more realistic. It's what mine looks like for the most part, or something like that. In tendons, there are three areas. There's the myotendinous junction, where the muscle fibers and the fibers in the tendon kind of come together. The tendon substance, that's the meat of the tendon, if you will, and the tendon insertion. Injuries largely occur either to the myotendinous junction, that's technically a strained or pulled muscle. Also, injuries can occur at the bony insertion. There's actually a couple of layers of cartilage here that help to provide an interface, but oftentimes wherein there is a traumatic bone injury and or traumatic tendon injury, or even tendonitis, the injury is often very close to or at the bony insertion itself. Okay, so let's look at the cells of a tendon. They're called fibroblasts. Sometimes they're called tenocytes, but they're specialized fibroblasts that we find specifically in tendons. And so they're embedded into the collagen fibers, as you see here. Their primary role is to construct an extracellular matrix that can resist against tension or pulling forces, just like a rope. In fact, it's a really good analogy because usually the collagen fibers will be kind of in a wavy or a crib or kind of a kinky appearance like this. Then as a muscle pulls on a tendon, it becomes taut and then becomes stiff, and then can cause joint rotation as force on the bone causes the bone to rotate around the joint like the elbow or wrist or shoulder or knee or hip. So these fibroblasts or tenocytes are really good at detecting mechanical stress and strain, oxygen, nutrients. They have receptors for growth hormone. They also have receptors for estrogen, testosterone, etc. About 60% of the weight of a tendon is water. Much of it is in a gel-like state bound to proteoglycans. Those are combinations of mostly carbohydrate and some protein that we find in bones, tendons, ligaments, cartilage, and even in skeletal muscle. They're highly charged. They can store a lot of water. They also have like charges that draw the water and can repel each other. We think that proteoglycans now have a much more important role than we thought 20 or 30 years ago. They can help with detection of mechanical stress and strain. They can help with the remodeling process. A couple of the most common proteoglycans are Versacan and Aggrecan. Also, there's Bioglycan. Technically, dystroglycan is also very closely related to a proteoglycan. As the name suggests, the glycan part, that just means it's a carbohydrate part. So a dystroglycan or biglycan, this just means there's a lot of carbohydrate. So these are proteoglycan-like proteins that we usually see bound to the cell membrane. Versican and aggrecan are usually part of the extracellular matrix, but they usually do bind or connect to proteins like integrins that are located by the cell membrane. So we think proteoglycans are also involved in the healing process in tendons and ligaments, and maybe the hypertrophy process that happens with exercise training. So that's pretty exciting. The collagen molecules in both tendons and ligaments are packed really tight. These are dense materials. The fiber orientation is going to be critical. In fact, these two pictures are pretty nice because you can see the collagen fibers, and when they're relaxed, again, they're kind of wavy or kinky looking. We call this a crimp. And when they're stretched, they become flatter. But most of the fibers are parallel with each other because the primary force that a tendon is going to see is tension. That's where the name comes from. A tendon is a connective tissue that can resist against tension or pulling forces. DON sort of means a substance. Okay, so tendons have a high percentage of collagen. It's mostly the type 1 collagen, makes up 90% of the non-water weight. Proteoglycans make up about 3 to 5% of the non-water weight, and they can act as mechanosensors. They're involved in remodeling, repair, and they bind to water. So much of the water is in kind of a bound state in bones and tendons and ligaments and cartilage. There is some elastin in tendons as well as ligaments. Some ligaments can have a lot of elastin, but 1 to 3% is pretty typical. And again, the collagen molecules are packed really tight. We're going to take a look at the fiber orientation here. Because tendons mostly see pulling forces or tension, they see sometimes a little shear near the bony insertion, but because they're mostly seeing tension as the muscles are pulling on the tendon, that means that the collagen fibers are going to be lined up in parallel to maximally resist the tension. So that's why they're lined up along the long or longitudinal axis. With ligaments, though, at a joint, you could see some bending forces. Someone might be twisting a joint, so you could see some torsion. You might see a little bit of shear force. In fact, you're probably going to see a lot of shear force where two bones are articulating, because when bones articulate, they tend to want to slide over each other. So the ligaments are going to try to protect against that. And because that is true, the fibroblast in a ligament will adapt to this different environment. It's not the same mechanical environment as a tendon. Sure, there's a lot of tension, but there's also some torsion, some shear, some bending forces. So we see a significant number of collagen fibers going across the longitudinal axis. When we talk about ligaments, we'll take a look at them. Skin isn't nearly as dense, but it's much different in terms of the type of loads that it sees. So because tendons mostly see tension, it's the most anisotropic. It's strongest against tension, it's pretty weak against compression. It's not very good against shear. Like if you cut, a rope, it's much easier to do than pulling it and getting it to fray. With a ligament, it's a little less anisotropic. Skin is the least anisotropic because they can deal with shear forces, they can deal with torsion, they can deal with pulling forces, they can deal with compressive forces. So they're looser packed, but they're the least anisotropic. The collagen fibers are arranged pretty much in parallel with each other for the most part. So there's some slack really that's built in. So when a muscle first starts to pull on a tendon, there's a little bit of slack, and that's good because muscles have little different material properties than tendons do. So as the muscle contracts, it gets stiffer and allows that muscle to get stiffer before the tendon really gets stiffer, so that they act as a unit and become matched, believe it or not, in their material properties, or more better matched in their material properties. So here we see this kind of wavy, this slack appearance. This corresponds to, in their stress strain curve for a tendon or a ligament, in what we call the toe region. And that's where these wavy collagen fibers are straightening out. And as they're straightening out, the material gets stiffer and stiffer and stiffer. I need to do it this way because I realize this is a mirror image. Yeah, that's something weird that I found about Zoom, is it gives you the mirror image of a person, or at least I haven't figured out how to reverse that yet. So here we see the collagen fibers. There's a tenocyte or a fibroblast. I will call it a fibroblast. And here are the fibroblasts here in between the fibers. A tendon or ligament can stretch about 10% before it will snap. And here's the toe region. This is a really good stress strain curve where we go from that wavy appearance to a straightened out appearance. That increases the stiffness. So the toe region is important because it may, as you're moving around, it helps you to feel less stiff. And also there's going to be less of a chance of an injury at the myotendinous junction. So this is one of the many mechanisms by which, like hoop strength in muscles that we talked about before, that help to reduce the risk of an injury that might occur at the myotendinous junction. We call that a muscle strain, or a pulled muscle with a large eccentric force. Collagen fibers, again, are arranged in parallel, and you've got this toe region. Okay, so here's another view, another stain of the collagen fibers in a tendon, and the wavy appearance is caused by cross-linking in between hydroxylysine molecules and between lysine and hydroxylysine molecules that's catalyzed by lysyl oxidase, an important enzyme. Okay, so here's the geometry of tendon fibers. If you painted these red or colored these in red, it would look a lot like what happens in skeletal muscle, and that's on purpose. So epitenon, endotenon, they directly connect with the epimysium, endomysium, paramysium. So you have layers of connective tissue that surround fiber bundles, and then fascicles, groups of tendon fibers. And so that means that the geometry of a tendon and a muscle that is attached to it should be pretty consistent. That's what we want to see. So it's these concentric sheaths, if you will. The epitenon surrounds the entire tendon. There's a visceral layer on top of it. Then you have a few layers of endotenon, which connect to the paramysium and endomysium and skeletal muscle. Everything is literally connected between the tendon and the muscle, maximizing hoop strength, reducing the risk of an injury to either the tendon or the muscle or even the bone. So we go from the collagen molecule at the nano level all the way to the micron level for the fibroblast, the endotenon. You're getting up close to the millimeter level, and then finally really centimeter level if you're talking about an entire muscle and tendon. So tendon bundles, again, looks like a skeletal muscle, doesn't it? So you have these fascicles which are surrounded by endotenon, which directly connects to endomysium. And again, within the microstructure, we can see the tenocytes or the fibroblasts embedded in the fibers. So really cool geometry. And again, it's continuous with the connective tissue, endomysium, paramysium, epimysium that we see in skeletal muscle. So really elegantly designed to maximize hoop strength to reduce the risk of injury to that muscle or the tendon or even the bone. So again, epitenon and endotenon are layers of connective tissue. The epitenon surrounds the entire tendon. On the outside of that is the visceral layer. This is where most of the blood supply is. There's some small blood vessels that sneak into the connective tissue, the endomysium that surrounds each fascicle. So there are some blood vessels that get in there. There's a lot of proteoglycans in there as well, helping to detect mechanical stress and strain and helping with the remodeling and the healing process. So this visceral layer, like I said, contains blood vessels, nerves, etc. The epitenon is continuous with the epimysium. Endotenon surrounds fascicles and collagen fibers and is again continuous with the endomysium and perimysium. So here we see a cross section of a tendon. We've just kind of chopped it in half. And here we see the fascicles. The white layer here is the epimysium, and then the visceral layer is on top. It's kind of akin or similar to the periosteum, if you will. So it's where the blood supply and the nerve supply, most of it is. And that's why when there is tendinitis, a lot of that will occur due to shear forces that are on the visceral layer. That's why it's sore. That's why there's a lot of pain. That's why there's a lot of inflammation and swelling. All of that, for the most part, is on the outside. A few blood vessels sneak into the tendon, usually associated with the fascicles and the connective tissue that surrounds the fascicles. This is a model for what we would tendon that we would see with the tibialis anterior, which produces dorsiflexion. The epitenon would surround the entire tendon, endotenon in between the or surrounding each fascicle, so in the inside of the tendon itself. Here's our little model. So it's like a box within a box within a box. You wrap collagen, a group of collagen fibers, then you wrap the fascicles, then you wrap the entire tendon. So that greatly increases, again, what we call the hoop strength. And this is actually kind of a nice view of a tendon unit where the blood vessels and some of the tendon cells, and it's not pictured here, but proteoglycans, all would be right in this area where it could really help with remodeling of the tendon. Now, because a lot of the tendon doesn't have blood vessels, bones have a lot more blood vessels than tendons do. Tendons and ligaments have much lower blood flow, and the number of blood vessels, capillaries, arterioles, arteries, is much lower. So that means that the cells that are associated with tendons and ligaments have to partially depend on diffusion. Yeah, they got some blood flow nearby, but you often have tendon cells that are some distance away from the vasculature. And that means that the mechanical action of movement, as well as diffusion, becomes a lot more important for a tendon and a ligament. And it also means, because the blood supply is lower, that the metabolism of these tissues is a lot slower. And this is where we really get into orthopedic problems. An orthopedist would almost rather see a compound fracture of like a tibia or a femur than a really bad, like a grade 2 and especially a grade 3 strain of a tendon or grade 3 sprain of a ligament. They'd much, much rather see the bone fracture. That's because these tissues take a long time to heal. And this is when we've added in exercise training and for prevention and exercise and rehab. So you got range of motion exercises, you have active exercises, and they help a lot. But you're still talking about months and months and maybe a year or longer to go through rehabilitation. So this is where the second revolution in orthopedics and biomechanics kicks in. And so these will be biologics, which can add stem cells, which can add growth factors, which can use medicines to inhibit key cytokines. Some really go up too much. And regulating this remodeling process, inflammatory process that can help to heal the tissue and do it a lot faster than we can now. Drug delivery, nanotechnology, hydrogels are going to be critically important in doing that. Here's some synovial tendon sheaths that change the direction of the tendon and increase lubrication, because those tendons are moving around in the body. They might do a lot of rubbing, the visceral layers on the outside. That could cause a lot of pain, discomfort, swelling, and inflammation. So with force transmittance, remember, we've got two mechanisms. We've got the longitudinal transfer of forces, and we have the parallel transfer of forces. parallel meaning alongside. This is a classic model you might have seen in your physiology text. When they made it years ago, we kind of really didn't know how it worked. The parallel element we thought was in the muscle fibers, which made a lot, I'm sorry, the series elastic element was in the fibers, including the contractile element, but it really turned out to be titin. That was the major spring inside a muscle fiber. And then the parallel element was the connective tissue, the endomysium, paramysium, epimysium connecting with the endotenon, epitenon. And so that muscle and that tendon were working together, maximizing hoop strength and increasing the parallel transfer of forces. So just as a reminder, this should look familiar. We talked about this with skeletal muscle. We've got this interdigitation between the muscle fibers and the tendon fibers. It increases the contact area between the muscle fibers and the tendon. That increases the stability. It's like an interlocking grip. And then we have the hoop strength. That's really a result of the parallel transfer down that connective tissue. And just as a reminder, to be able to do that, we transfer 50%. Remember, 50% of the force being produced in a muscle is going down the sarcomeres in series. 50% is in parallel. But the only way to get that force to the outside is through the Z disc and through the costomeres, the dystrophin glycoprotein complex, the caveoli, as well as the focal adhesion complex. That's how we get the force to the outside. These proteins, as we mentioned, are kind of the weakest link. There can be many problems with these proteins that happen with muscular dystrophies, also happens with aging, and recently we've discovered is also a problem with metabolic disease, including type 2 diabetes. So that's why some people with type 2 diabetes have real problems in terms of skeletal muscle strength and endurance. So again, here's the end of a muscle fiber. This is an electron micrograph, one of my favorites. And here you see the endotenon being continuous with the endomysium. That's pretty exciting. That means we can transfer that force in parallel, meaning alongside. You don't want the parallel force to be at a 90-degree angle. It's going to be parallel or alongside the series force. This arrow just tells us that in order to produce that force so that the connective tissue and the fiber shorten at the same rate, the only way we can do that is to move that force through the Z disc and through those costomeres. But the force itself is alongside. So when the muscle is shortening, the connective tissue is shortening. When the muscle is lengthening, the connective tissue is also lengthening at the same rate, roughly, so that the amount of shear is in the Goldilocks zone. Not too much, but not too little. If it's too little, then the muscle atrophies. Too much, then we get a muscle injury. Another place where we can have some problems is at the tendon insertion. And you have these tendon fibers going into bone material. That's really a tough interface because bone's super, super stiff and strong. And even against tension, and the tendons are a little bit more stretchy, and they're even more anisotropic. Their resistance against compressive forces and shear stress is a lot less. So we have to come up with some type of transition zone. And so we have the tendon, fiber cartilage, and that's like the menisci of your knee or vertebral discs. Mineralized fiber cartilage, that's like the bone you might see in a child. We also see mineralized fiber cartilage when a bone is undergoing repair. And then here's some hard ossified adult bone. So this transition zone is critical in terms of a tendon pulling on that bone so it doesn't come out. A lot of traumatic tendon injuries occur usually very close or at the insertion site. Very close or at the insertion site. Here, finally, mechanical material properties. We've got this toe region. We saw this once before on another graph. So here's where those collagen fibers straighten out. Here we have the linear region. This is what happens when you're playing tennis, golf, running, lifting weights, etc. Then you get to the elastic limit. Just before that, we can get a mild injury, a class 1 strain of a tendon. After the yield point, you go from the elastic region to the plastic region. With plastic region, that tendon has been stretched and it's not going to go back into its original shape unless we do some really good rehabilitation starting almost immediately. So a class 2 strain would occur in the plastic region. The failure point will be a tear or a rupture of a tendon, like an Achilles tendon rupture. Very bad news. That takes a long time to recover. The good news is we don't use casting anymore after surgery. We use a boot and then go into rehab after 6 or 8 weeks in the boot. And the prognosis is much, much better. So in a year, they're in really pretty good shape, we think, today. Once we start adding in some biologicals, we might be able to cut it down to 6 months or less. So really exciting. Okay, this is just a reminder that toe region is where the collagen fibers are kind of kinky and then they straighten out. I mentioned before that metabolism in a tendon or a ligament is really slow. So the liver and muscle, and this is a muscle at rest. If this muscle were exercising, the oxygen consumption would be way, way up here, way past the end of the slide. Tendons and ligaments, notice the oxygen consumption is really low. It's kind of ridiculously low. And it means that with low metabolism, that means remodeling is slow. It may take a year or longer to turn over that collagen in a tendon. During the healing process, because we have a slow metabolism, there are 3 phases and they can take months to years. Yes, that's not a mistake, especially without good rehab and without in the future. And you guys are going to get to see it. Hopefully I'll get to see it. I'm pretty sure I'll get to see it in maybe 20, 30 years. What we're going to see is a lot of people getting like a hydrogel wrap that will have stem cells, growth factors, progenitor cells, some biologics, some medicine to be able to manage the cytokines. Not too much, not too little. You got to keep in the Goldilocks zone. So with like the COVID virus, that's one of the problems, is keeping your immune system in that Goldilocks zone. Not too much, not too little. So it takes, you can see, wow, 300 to 500 days. Now that turnover is faster when there's an injury or when there's exercise training. So if you want to increase turnover of collagen, your tendons and ligaments, exercise is a good way to do that. It means it may take months or longer to repair, rebuild, repair tendons and ligaments. As we get older, there's some changes in the material properties of tendons. They become weaker. It's not that much weaker. It's about 20, 25% by age 70. We think a lot of that is directly related to weakness in muscles. Makes sense if you think about it. The more tension we see more often being pulled by muscles on the tendons into the bone, the greater the strength is going to be. And that's exactly what we see. We do see a significant increase in stiffness, and that's because increased cross-linking due to lysyl oxidase. Development just really continues, and also glycation, which might happen with diabetes, pre-diabetes, where carbohydrates accelerate the cross-linking process. So free radicals, glycation are 2 mechanisms. The lysyl oxidase mechanism is kind of continuous, but if there are more free radicals, more glycation, you're going to see a lot more cross-linking. What that means is that's going to increase the stiffness of tendons, also the stiffness of ligaments, as well as the stiffness of arteries and arterioles, which could increase a person's blood pressure and cause hypertension. So lysyl oxidase, we think, is increasing the amount of cross-linking as you get older. There's an increase in oxidative stress, free radicals, as well as an increase in glycation. And as I mentioned, that affects tendons, ligaments, arteries, as well as your skin. We see significant increase in the stiffness because those cross links are primarily going to affect the toe region in a stress strain curve. We look at a stress strain curve, go back at right there. This is largely going to be where the effect is. It's going to actually affect the stiffness in the toe region. Proteoglycan content decreases, and this could be a significant factor in terms of remodeling and repair. Would really slow down that process. It's somewhat similar to what we see with tendinopathy, even though what usually happens there is all chronic inflammation. But it can reverse itself. You can get tendinitis that becomes avascular, and the prognosis there is much worse. Then you actually have to stimulate that. But with aging, you see a reduction in proteoglycans. You also see this in bones as well as ligaments and especially cartilage. And that affects the material properties. That tendon is going to be a little bit more brittle with aging, but mostly it's not going to be as strong. It's going to lose thickness. And when there's less water in that gel-like state, mechanotransduction is affected, as well as, again, the healing and repair process. So, okay, this one's a little bit busy, but again, with aging, there's an increase in stiffness, primarily in the toe region. We have increased cross-linking, increased glycation, etc. So these are the effects of aging in a tendon. And you can see the collagen level is actually decreased. There's a lot more free water, but less bound water. This is a marker, hydroxylysyl pyridinoline, and that is a marker of stiffness that's increased. Lysyl pyridinoline, that's also a marker of stiffness. That's pentosidine, that's also another marker of stiffness. They're all up. And when we look at a fiber that's either glycated or cross-linked, it's almost always going to be stiffer. And so that's what we see when the effect of looking at the effect of aging on tendons. In that toe region, we see a left shift, and that means that the tendon is stiffer. So when you first start to pull on a tendon, it's already pretty stiff. And that means that there's a difference in the material properties between the tendon and the muscle. That means that muscle at the myotendinous junction is more likely to be injured. And that's indeed what happens. You see muscle damage and muscle soreness. Both of those are increased in muscles with the aging process. The repair and remodeling process is also a lot slower for the muscle as well as the tendon. And you're also going to feel stiffer. It's one of the reasons people feel more stiff. It means that tendons and ligaments have increased cross-linking, increased stiffness. So that indeed is what happens. When there is an acute injury or a material fatigue injury, where does it occur? Well, usually near the insertion, especially in a young person. In the tendon body, more common with adults. But you know, with tendonitis, it's almost always very near the insertion, because then you get tension and shear. That combination of tension and shear repeated over and over again, that can cause tendonitis in the rotator cuff, around the elbow, around the knee, etc. So most tendon injuries are actually material fatigue injuries. A strain of a tendon is pretty rare, and when it happens, it usually occurs right at the tendon insertion. And when you get an injury between the muscle and the tendon, we usually call that a muscle strain because the muscle fibers are injured right by the myotendinous junction. So tendonitis is a material fatigue injury. It's an overuse injury characterized by chronic inflammation, chronic irritation, and pain. It's usually some combination of tension and shear force near the insertion. Tennis elbow is usually on the outside, little league elbows on the inside, if you were wondering. Rotator cuff injuries, 10 to 12 weeks for a full recovery. For tendonitis, it actually takes a few months because you have this prolonged inflammatory and reparative process. That takes a long time, and it takes a while to build that blood supply. With a strain, that's a traumatic injury. These are actually a bit more rare. A mild strain would be a class 2 strain, and I'm sorry, mild strain would be a class 1 strain, and a moderate strain will be a class 2. A mild strain occurs just before the yield point. So if we go back, there we go. If we go back, here's a stress strain curve. It's going to occur right here, just before the yield point at the end of the elastic region. It means only a few fibers have been injured. So that's the good news. So with a class 1 sprain, you have kind of prolonged inflammation. You do get some scar tissue. Anytime there's a tendon or ligament injury, you're going to have some scar tissue being formed. What we're trying to do, and this is going to include the biologics in the second revolution of sports medicine or orthopedics, we're going to be able to reduce the amount of scar tissue while increasing the normal tissue that gets repaired. A lot of times now you get a significant amount of scar tissue as well as some normal tendon with ligament, but a lot of scar tissue. And the difference is there are different types of cells called myofibroblasts, which proliferate, and they just try to do the job quickly. You usually see them when you have either M1 macrophages or a special type of M2 macrophage that you see with chronic inflammation as opposed to acute inflammation. When you have that chronic inflammation, then what can happen is you get more myofibroblasts, which produce a little different material. Tendons are really highly organized and dense in their fibers. Scar tissue is kind of random in terms of their fibers. It's not really very well organized. They don't have as much blood flow. They have a hard time dealing with shear forces. So it's like when you get a cut on your skin. I call it the body's Bondo. It's just patchwork. Let's get it fixed really, really quickly. We think with rehabilitation, we can reduce the scar tissue, we know we can, and increase the healthy tissue. We need a little extra help though. So it's going to take some hydrogels. It's going to take some progenitor cells in there, some growth factors, maybe some heat shock proteins, some drugs to try to promote protein synthesis while reducing and managing the amount of inflammation. Not too much, not too little. Moderate to class 2 sprain, a lateral sprain of the ankle, really common on the outside of the ankle. Those ligaments can become stretched either with a moderate strain or a class 3 strain, a rupture. That easily happens. So I've got and that can cause lots of laxity in the joint, where that means too much flexibility. So I got lots of laxity. My right ankle is really flexible, but that doesn't mean it's stable. It's not stable. So I'd have to watch out if I played a lot of basketball. I don't anymore. I used to play a lot, but maybe I should play a bit more, lose some weight, right? But I'm worried about that right ankle. A rupture or tear, that's sometimes called a class 3 strain. Let me move this. Cool, editing as we go. There we go. Class 3 strain. Previous injuries increased laxity, so my right ankle is now susceptible to even a worse strain or sprain. So these tendons can be really super important in terms of how well you do. So sprain versus strain. Sprains refer to a ligament injury, what we consider a classic joint sprain. Strains refer to a pulled tendon. Both of these are occurring on the lateral side of the foot. And with these, the posterior talofibular joints between the talus bone and the fibula, you have a number of ligaments that can be easily stretched. As I mentioned, my right ankle has had a few of those. There may be some tendon injuries as well. in there as well. With therapeutics, the RICE method: rest, ice, compression, elevation, non-steroidal anti-inflammatory drugs. Surgery may be needed, especially with a class 3 strain, tendon tears, ruptures. We've gotten a lot better at dealing with Achilles tendon blowout or rupture. Today, we're going to try to use more regenerative implants. They could be hydrogels. People were using injections of platelet-rich plasma. That's something else you can actually put into the hydrogel, which works like a gummy bear or works like Jell-O. It's really well hydrated. You're going to have basically these days some natural compounds which are going to provide a scaffolding to be able to store water and store drugs. And it worked like the patch that you might see for initially, it was for nicotine for people who are smokers. And now they use it for lots of different drugs to treat osteoporosis and a number of other conditions, osteoarthritis as well, and rheumatoid arthritis. So hydrogel, there we go, hydrogel wraps, we think that's one potential way to deliver the drugs, maybe nanotechnology as well. So the future is going to be pretty exciting, I think. So real briefly, I'm going to try to finish this tendon segment. We're going to run a little long. It does mean our discussion about ligaments won't take as long because we won't have to go over bone or tendon related material. In terms of therapeutics for tendon, it's really the first revolution is all about exercise, passive range of motion exercises, active exercises, because you need some mechanical stress to promote healing. You want to keep it in that Goldilocks zone, not too much, not too little, not too soon, not too late. You want early intervention, especially with range of motion exercises. They have these CPM machines, continuous passive motion. You want to increase blood flow, increase mechanical action, decrease scar tissue. We're going to do that by boosting. One of the things that exercise is going to do is boost those growth factors, which are going to drive the remodeling and repair process. With a mild strain or tendonitis, it could take weeks. The inflammatory period can be long, and I kind of infuse that into the reparative period. This is optimistic as I'm looking at it. But you get a spike in inflammation, and that starts to come down during that reparative process. But the inflammation is involved in not only cleanup of the damaged tissue, but increasing, remodeling, enhancing the protein synthesis that's going to be involved in the repair process. So the reparative process is next, can last a month or two. The remodeling process can last 2 months, a year, can last a long time. With tendonitis and a mild strain, class 1 strain, this whole process should take really a month or two. With a moderate or severe strain, we're talking about 6 months, a year, maybe even longer, especially with good rehabilitation. And as I said, because we're not casting as much, that process is getting a little faster. And with platelet-rich plasma, and when we think we're going to have better drug delivery with hydrogels and with nanotechnology, we'll be able to get gene therapy, platelet-rich plasma, growth factors, vascular endothelial growth factor. VEGF always comes first. You got to have angiogenesis, new blood vessels before you rebuild. Platelet-derived growth factor, IGF-1, TGF-beta, stem cells, and then the drug delivery to get it there. So we're getting better at this. And casting, even if the ligament or tendon, in this case, even if tendons and ligaments aren't injured, they cause, in my view, a mechanical damage, or mechanical injury is maybe the best way to say it, in that immobilization reduces stiffness, the ligaments and tendons get softer, reduces the strength, reduces the toughness. A lot of people make the mistake and think because once you're immobilized, when you get out of the cast, you feel stiffer, that the materials are physically stiffer. No, that's not correct. It's like when you have a hot, humid day and the air feels thick outside, we know that is just an illusion that we share. So there's an illusion of stiffness, but the materials are not stiff. And that's because you get a joint capsule contracture. You also have swelling and inflammation that causes pressure on free nerve endings. And you also have some changes in the muscle. But the tendons and the ligaments, due to casting, are not stiffer. They are less stiff. So we look at a stress strain curve. We can see this. The slope of the line in a stress strain curve tells us about the stiffness. This is Young's modulus. And as that stiffness decreases, the slope of the line decreases. So remember, the slope of any line is the change in the y variable divided by the change in the x variable. The change in strength of mobilization, it really tanks. This is normal activity. With exercise, you get a continued increase. Overtraining, though, can cause a problem, so be careful about that. So tendon strength goes down, tendon thickness decreases, tendon stiffness decreases. Even though you feel more stiff, the material is not stiffer. Those stress strain curves tell you so. On your exam, you're going to have to evaluate and maybe even draw for me a stress strain curve or 2 or 3. Reduction in energy absorption, that's the toughness. That's really an indication of the stiffness, strength, ductility, all of that put together. Those tendons are a lot less tough. And it takes months to a year to recover from immobilization. When you combine surgery with immobilization, 1 to 2 years. If you even recover at all, that's with rehabilitation. So plaster is disaster. Stay away from it. Okay, so this is a classic study from way back, I think in the 1970s, or maybe this is early 80s, that said, this casting stuff, it's not a good idea. Okay, so we have 3 groups. One group is casted the entire time after surgery. The other group is casted for 3 weeks and then undergoes exercises. The last group started the exercise process immediately. That's group 3. So this is the strength. What we want to be is 100%, right? 100%, this is the full strength of the tendon. So weeks after the surgery, and this is not quite 3 months, almost 3 months, close to it. Look at group 1. That's the casted group. 22% of normal. That's 3 months out. That's pretty bad. That means that tendon's way more likely to get injured. Group 2, it's a little better. It's about 35%. Right? Maybe in another 6 months, you might get there. Group 3, it's the only group that's going to make it there by 6 months. Okay? So this is after surgery or after a rupture, 50%. After 12 weeks. So that those range of motion exercises, active exercises, that's the only way to get those material properties back. And remember, for a tendon or a ligament, the material properties are the health of the tendon or ligament. This is another look at this from way back in the 1960s. This is vascular volume. That's really a marker of how many capillaries and arterioles you have. What this is saying is that the muscles and the tendons are both atrophying with casting. And this was with, I think, about 8 weeks of immobilization. With 6 to 8 to 12 weeks of immobilization, you're going to have significant atrophy, significant loss in strength. In skeletal muscle, as the muscles atrophy, you lose blood vessels at about the same rate. And muscles have a fairly high metabolism. They're fairly well vascularized. They can recover pretty fast. However, a tendon or a ligament that's been immobilized doesn't recover fast. The reason it doesn't recover fast is it not only has a low blood flow to begin with, but then after immobilization, the amount of blood flow per volume. So as the tendon and ligaments are shrinking, the capillarization is being reduced at a much faster rate, almost twice, probably about 2 or 3 times the rate. So when we look at the vascular volume, it's really low. You're going to need a lot of angiogenesis to recover. That's going to need a really big inflammatory period. That's why it hurts so much. That's why there's a lot of discomfort, and it lasts a long time, whether it is you have tendonitis or surgery. It's going to take a long time to recover. And if you add in casting, oh my goodness, you're looking at an extra year pretty much. So anything to, any alternative would be a great thing. So soft cast, support, a boot, anything's better. And plus you can take them off and scratch and that type of stuff. And you can do, when it's appropriate, when the physician feels like things are healed enough, you can start the range of motion exercises. Hopefully that won't be too long after surgery or after a rupture. You can get started. Sometimes people start the day of surgery for a ligament or a tendon. So this is why this person is smiling. They didn't have to go in a cast after surgery for an Achilles tendon rupture. They're in the boot, and you get to move around in one of these little dollies. These are great. They got wheels. They can move along really fast. It's kind of cool. The surgery is a lot better than it used to be. It's less invasive. You don't get the huge scar and gash like you used to. So with better surgery, sometimes they'll even put a turnbuckle in and glue that into the bone, which will actually heal a lot faster. That's actually a pretty good way to go. If you try to attach the tendon to its stump, that's a little harder. That's why we need a hydrogel wrap, I think, in nanotechnology to deliver stem cells and growth factors and all kinds of good stuff in the future. With exercise training, this is from Savio Wu's lab, 1980 or so, you see an increase in strength, increased insertion strength, slight hypertrophy, and increased toughness. All of those will increase with exercise training. So here we see the exercise group. It's indeed a little stiffer. So I'm going to add in stiffness. This is the peak strength. That's way up. So a little stiffer, big increase in strength. If you looked at the area under the curve, which would tell you about the toughness, it's up as well. So that's really, really super good. In the exercise group, I think the strain of failure was slightly reduced. So there wasn't much of an increase in ductility. In fact, there's a slight decrease in ductility. But the big news is the increase in strength and stiffness, which means it's tougher. So during wound healing with therapeutics, whether it's a rupture, this is what we're looking at in the future. Gene therapy, increasing key genes like these growth factors. Platelet-rich plasma, which has these growth factors in it. And then adding the growth factors directly. Any of those things will work. VEGF, platelet-derived growth factor, IGF-1, TGF-beta. These are bone morphogenic proteins. I got PDGF in there twice. There we go. Connective tissue growth factor, stem cells, then the delivery, how to get it there. Hydrogels, nanotechnology, looks like that's going to be the wave of the future. So people in biomechanics and biomedical engineering are working on this stuff now. This is where the future is in biomechanics. Really exciting area. So we can take platelet-rich plasma, which you get from spinning down your blood. You spin down the serum or plasma, and then you get the platelet-rich portion. This won't produce more platelets, includes platelets. The platelets can produce lots of growth factors, like VEGF to increase the vascularization, platelet-derived growth factor, TGF-beta, connective tissue growth factor, fibroblast growth factor, and then with drug delivery and stem cells, it is going to be really super exciting. So hydrogels, they work really like the patch. And so the patch can deliver materials at a certain rate due to what we call the pore size. So these gummy bears can leak at a certain rate, if that makes sense. So you can actually figure out how much drug can be delivered. So if you imagine surgically putting a patch like this, which would be biodegradable, by the way, you could put it around an injured tendon or an injured ligament, which could include antibodies, platelet-rich plasma, growth factors, progenitor or stem cells, all kinds of cool stuff. The hydrogels themselves can be made of, last two are natural materials, and they will break down. They're used today. You can even replace tissues as well as heal tissues. So you can replace cartilage, skeletal muscle. It'll actually become that type of tissue. Ligaments, lung, skin, with 3D bioprinting. I think at Wake Forest, they 3D bioprint 23 different types of tissues. Pretty amazing. So this is the stuff that you're going to get to see in the future. Nanotech, hydrogels, drug delivery, getting everything from platelet-rich plasma, progenitor cells, growth factors, antibodies, other biologicals, getting them to the tissue that is trying to repair itself. Okay, folks, that is it for today's lecture about tendon biomechanics, as well as that tail end of bone biomechanics. And the next one will be, I promise, shorter, and it'll be focused on ligament biomechanics. So there'll be, you'll notice a lot of things will be shared with tendon biomechanics. There's similar cells, similar types of tissues, but I'm going to point out some of the differences, especially related to the way the collagen and the elastin fibers are laid down. So there's some aspects that are quite different. The effects of aging are actually quite a bit different, much more dramatic, much worse than they are for tendons. Both, though, have a significant increase in stiffness in the toe region. So that's it for today, and we'll see you next time, which will be tomorrow. I'll record this tomorrow.